In the past, we usually use multiple plastic stents to expand endoscopic multiple stenosis, but recently we began to directly use the covered metal stent to expand for 6 to 8 months, and most patients have the stents extracted after 8 to 16 months of treatment. Treatment of non-anastomotic stenosis include dilation plus stenting to expand, choose dilatation cassette or dilation balloon in 6 to 8 mm diameter. The numbers of stents depends on the intraoperative situation, and a repeat ERCP every 3 months can minimize the risk of stent blockage, cholangiocytis, and bile duct stone. This is we always use the cassette and balloon. For this patient, during the first time, it is not necessary to pursue perfection, and the operation method should be decided according to the situation. We consider that the biliary cast did not fall off completely and wait for the treatment when it is for endoscopic treatment again. This is the second operation. We used the balloon dilation again, and more stents was placed. Sometimes we meet a special situation we called complete obstructive or benign biliary structures. Just like this, we can see the donor bile duct and the recipient bile duct are not connected with each other at anastomosis. Here we introduce a revolutionary minimally invasive method, the magnetic compression anastomosis. You can see we first performed PDBD, and every week the cassette was replaced with a large cassette to enlarge the tract from 8.5 to 16 French. Then the sub-magnet connected to a 15 long stick was advanced into the upper end of the structure with a 14 French partial. Then we do ERCP. ERCP was performed after successful papillary cannulation. Mid-EST was performed, followed by balloon dilatation of the papilla. The parent magnet was carefully inserted to the common bile duct with an 8.5 French partial. During the insertion of the parent magnet into the lower end of the structure, the parent and the sub-magnets would attract each other once their position was properly aligned. We always do abdominal X-ray film just about 1 day after or 3 days after the operation to check the complaint of the magnet. When the volume of bile drainage via the PDBD is decreased, we can collagenography is performed to confirm recognition. If the biliary tract was recognized, ERCP was performed to remove the magnet. We insert a full covered metallic stent into the biliary tract for more than 6 months. We enrolled 9 patients who underwent magnet for benign biliary strictures between 2012 and 2018. Our work is published in surgical endoscopy. Okay, summary. biliary stricture is the most common complication after transplantation. ERCP is the first choice for biliary stricture after liver transplantation. ERCP can cure anastomotic stenosis, and it can improve the biliary tract condition of patients with non-anastomotic stenosis and create the opportunity for follow-up surgery.